Welcome, everyone. The second of a series of the AO wrist courses. I'm Jesse Jupiter. I'm the moderator, and our other faculty from Ohio, we have two, Peter Stern and Harry Hoyne, and from Boston, we have Charles Cassidy and myself. So country is well represented. These are the disclosures of the four faculty. They're on the Hand Society and Academy websites as well. We ask all of you to mute your microphone, turn your videos off, and use the Q&A for questions, not the chat box. We hope that we'll cover this subject in great detail, but we'll try to do it in a way that's very interactive. And I'll go through these learning objectives that you see here and finish up with these as well. This is the course outline from starting 2 weeks ago and it's going through the beginning of April. And we hope that all of you can join in and participate. At the end of this, all of this will be on Zoom for those of you who are registered AO North America. And as always, consistent with AO, we share a passion for trauma excellence around the world. Well, let's get into it. And what we're going to do is, besides my moderation, Dr. Cassidy will give an overview of what happens in deformity. Dr. Hoyne look at some of the pitfalls and pearls of corrective osteotomy. I will try to cover malunions on an intra-articular involvement, and Peter Stern will look at salvage of problems when osteotomy may not be indicated. To start this out, I want to show you this case. And it's very straightforward. It's a 43-year-old woman who clearly has a deformity. And if you notice in the clinical picture, she seems to have a slightly swollen hand. And on exam, the intrinsics are somewhat tight. Through the course, we're going to look at all of these issues per se, but I'm going to ask Dr. Cassidy about timing. Chuck, when you're faced with a not totally compliant hand, what do you do?
Well, we always worry about indolent carpal tunnel syndrome. So carpal tunnel syndrome can manifest in different ways, but one of them is just a swollen, stiff hand. So we have a high degree of suspicion for that. And that's probably more important than the fracture itself.
Okay.
We can talk about fracture factors a little bit later, I think.
You'd want to evaluate that. And how about Harry? How would you do preoperative planning of this type of deformity? What's your method?
There's good radiographs you have there of the both injured side and contralateral, and I think CT scan planning gets you to the next level if need be, and it also can maybe identify any other intracarpal issues.
Okay, so you'd look at the carpal alignment as well as the deformity of the radius. Peter Stern, if you had to approach this deformity, just off the top of your head, would you do it from a dorsal approach, volar approach, or does it matter? Dr. Stern. Okay.
Sorry, I was muted, Jesse. So I probably, I think it depends, but I probably would do this from a palmar approach.
Okay.
A little more comfortable, but historically dorsal, but more recently palmar.
Good. All right. So keep this case in mind as we go through other cases, and we'll hopefully finish up with what was done with this. So Dr. Cassidy will provide us with an overview of this situation, please.
Awesome. If you could exit.
Yes, sir.
And
Okay.
All right. So I thought my mentor, Jesse, gave me an easy topic to cover. This is not so straightforward. Hopefully you will have learned something by the end of the session. The term form follows function was made by Louis Sullivan, who's a Boston architect in the late 1800s. He's the father of the skyscraper. But before that, Abraham Colles had taught us that patients with distal radius fractures do well in spite of deformity. Mildred's an example. So Mildred is a patient who I operated on years ago with calcium phosphate. And you could see the great reduction and it collapsed. And I was feeling awful about that. Well, it turned out that she had had a distal radius fracture on the other side years earlier. And she was a happy lady. So she did not read the architectural textbooks. And that is similar to some of the biomechanical studies that have been performed over the years. So this study from Patterson and Villegas demonstrated that the wrist can tolerate 5 degrees of radial inclination. So that's loss of 15 degrees, 28 degrees of dorsal tilt, and 6 millimeters of ulnar positive variance without significant biomechanical change. Which explains why most of these patients actually do fairly well, especially the elderly patients. So let's have a couple of definitions here. So what is the definition of a malunion? Symptomatic malalignment of the distal radius, or how about potentially symptomatic malalignment of the distal radius? It's important to note that associated ligament injuries are common and may be a principal determinant of outcome in these fractures. So rather than think about radiographic parameters, let's just think about who does not do well following these injuries. And I think we would all agree with this. Associated median neuropathy and digital stiffness, younger patients, patients with loss of rotation, especially supination, self-perception issues, and a painful wrist. So those are pretty easy. And this was a study by Watanabe where he looked at the center of the capitate with relationship to the volar surface of the radius shaft. And you can see on the left side, the center of the capitate is volar in a normal wrist. And he determined that if the center of the capitate translates dorsally more than a centimeter, the patients are 21 times more likely to develop carpal tunnel syndrome. Interesting. And you could see the deformity displacement of the flexor tendon. So it's not surprising that these patients could develop carpal tunnel and a stiff wrist. How about younger patients? It turns out that patients younger than age 50 have about a 10 times the risk of having problems from a distal radius fracture, whereas patients over 65 have only a 2 times the risk of having problems. In a study of 103 malunion patients, looking at all kinds of parameters, including radiographic parameters and outcome, concluded that the only determinant was a younger age. Patients who were younger were more likely to have surgery than older patients. We talked a little bit about loss of rotation, and this is an interesting study, a cadaver-based study, where if you see dorsal angulation, you see loss of volar tilt has a couple of effects. One is the ulna is relatively more volar, and then second is that the radial ligaments get tighter in pronation. And you can see that the distal radial joint is not quite congruent. And that's even exacerbated more so in patients with volar malunions, like the ones on the right. The top right one is a subtle one, but that patient lost some supination. And the one on the bottom right, you can see that the distal radial joint is totally off. And those patients would not be happy if their radius is not treated. How about self-perception? I learned a lot one day. These are 2 patients who I saw on the same day. Patient on the left came in for a trigger finger. I looked at her wrist. I said, "Is it bothering you?" She said, "No, I'm totally fine." Patient on the right from the suburbs, affluent, had been treated in a cast for a minimally displaced distal radius fracture, didn't like the bump and said, "This is malpractice." And I said, "Does it hurt?" And she said, "No." So pain is one of those things that's very difficult to quantify and understand, particularly in light of radiographs. But let's look at this study that looked at radiographs. These patients were younger patients at the time of injury, as you see. And their definition of malunion was greater than 10 degrees dorsal tilt, greater than 3 millimeters ulnar variance, and loss of radial inclination of, less than 15 degrees radial inclination. And they showed that these patients who had, regardless of the treatment, if their radiographic outcome were that, they had a malunion, they had worse DASH scores, more pain, and lower satisfaction. Interestingly, their motion and strength were not impacted though. And arthritis was not significant, ulnar styloid non-union, not significant. So a question Jesse and I pondered years ago, which radiographic parameters would guarantee a poor result? I have no clue. But let's go through some. How about this? Dorsal tilt greater than 10 degrees. And that can result in secondary midcarpal instability, as you see here, that zigzag pattern. Jesse showed one earlier. That definitely increases radioscaphoid contact and ulnar carpal contact. Clearly, you're going to lose some flexion if you have an extension malunion and may have some weakness of grip. But it also has an effect on the distal radial joint, including incongruence, tightening of the interosseous membrane, loss of rotation, and strain on the TFCC area. How about ulnar positive variance? That term ulnar impaction. Important to compare to the uninjured wrist, and it's quite variable. So we could say more than 3 millimeters, but it could be as little as 2 or as much as 10 before patients develop significant ulnar impaction symptoms. What are they? They're manifest by ulnar-sided wrist pain. They can develop ulnar carpal arthritis and distal radial ulnar joint arthritis. And the loss of rotation, that's a really important one. How about loss of radial inclination? By itself, it's usually not a problem. It's usually part of a more complex deformity. There's some theoretical impact of the altered course of the flexor tendons and weakness, but can produce cosmetic change. How about articular step-off? We'll talk more about this, but greater than 1 millimeter, as Jesse had demonstrated years and years ago, these patients will develop arthritis. Other studies have shown that they recover slower than patients who don't have an articular fracture, but the outcome doesn't seem to be that significant long-term. And Jesse has taught me that the location of the step-off matters. It's not just the step-off. If it's between the scaphoid and lunate facets, it may not be as significant as if it's within a facet. How about one? This is underappreciated, I would say, a radial shift. So radial shift, as you see here, especially if the fracture is very distal, can result in impingement in the distal radial ulnar joint. Pre-operative planning, we need to understand the deformity and comparison views as we talked about earlier. This is an interesting patient. She's 17, she's a gymnast, she's referred for an ulnar shortening. She had ulnar-sided wrist pain and limited supination, and the thought was that she had a growth arrest from gymnastics. If you look at the lateral, so she looks like she's really ulnar positive. If you look at the lateral, it doesn't look too bad, but if we look at the increased volar tilt and just get an x-ray along that plane, you can see it's not so much that she's ulnar positive. That's not bad, right? She's got increased volar tilt. And if you compare it to the other side, very similar. So she has volar angulated malunion with loss of supination. So the treatment is not to shorten her ulna, it's to treat the radius. Here's the lateral. You can see if you look on the right side, the comparison view, normal palmar tilt, left increased palmar tilt, and the treatment is just an extension osteotomy of the radius, and there you go. So it's not really a length problem, although you do gain some length by correcting the tilt. That's what it was beforehand. That's what it was after. There's no bone graft that's jacking the whole thing open. It's just correcting the tilt. How about CT? CT is important for malrotation, articular step-off, and distal radial joint congruity. This patient, another volar malunion. You can see very distal fracture. There's an intra-articular split. Is that thing significant? CT is very helpful for this. And this is my favorite image, the one with the orange circle. You can see a pronation malunion. And so her loss of supination is multifactorial, but a big component of that is the distal radius is overpronated. You can see the distal segment is pretty small. You can see the fragment is pronated. The articular fracture, although it looked like it was a pretty gapped, is not a significant part of this. And you can just treat basically derotate the radius, put it back up, and you're all set. 3D modeling can be helpful for complex articular fractures, and it can be helpful for some extra-articular fractures like this one, where you have a lot of deformity. When you have a deformity like this, there are some soft tissue issues, and you're not necessarily going to correct them by just treating the radius alone. And we'll see more of this, but this is from Materialize. This is an example of corrective osteotomy where a CT scan results in a jig that is applied properly, and then you can do the osteotomy if it's in the right spot, and then Eureka, the radius is beautiful. But in instances like this, you got to think about shortening the ulna too. You can't get it all through the radius. And then finally, timing. There are two concepts that Jesse has taught us: nascent malunion, early. So where early intervention could potentially decrease the overall period of disability. Whereas the other option is intentional delay. So like in a severely comminuted fracture where most of it's aligned pretty well and there's one spot that's not great, you can let the fracture heal first and then simplify the subsequent surgery. Or a fracture that's really, really distal that it may be hard to fix. You could let it heal and then make an osteotomy at an away site. But there's no free lunch with malunion surgery. In the last 2 years, there have been 2 papers. So one demonstrated a 50% complication rate with osteotomies. The second from the Harvard program demonstrated that there's a lower complication rate with the volar correction than dorsal correction, but it's not insignificant. And then finally, I like this phrase, anatomic reduction and fixation does not necessarily lead to better outcomes, but instead it helps to avoid poor ones. Thanks.
Thank you. Can you open your screen?
If I can do it. Yep, here we go. Yep.
Okay. Oh boy. Okay. Thank you. I didn't notice any questions in the chat Q&A area per se, but Chuck, how often do you think you need to use the computer-generated pre-op planning? It's gotten a lot of interest.
Yeah, I think it's you know, there's a sort of the practical aspect of how do you get that thing paid for? And the hospitals, at least my hospital, is not really in favor of it. It ends up being bundled into the surgery, so it's an added expense, and the hospital loses money off of it. So I would reserve it for on a very limited basis for complex intra-articular malunions. I think the rest you could do by CT, like malrotation. I think you can get with a CT. Involvement of the distal radial ulnar joint, you can get that with a CT. So I think the indications are really limited, although it's intriguing, that's for sure.
Okay. Well, Chuck, there's a question to you about the 17-year-old. The PA showed ulnar positive variance, but subsequent fluoro showed it wasn't. Can you clarify how you obtained the fluoro view?
So I just went down the volar inclination of the radius. So if you look at my hand on the, I don't know if you could see it, but okay. So if you had a beam that shot exactly parallel to the articular surface, then you would get the tilt. So in this instance, there was increased palmar tilt, and the beam was oriented in this direction so that the volar and dorsal lips overlapped.
Okay, good. There's a couple of questions about the rotation deformity. And so what I'd like to do is get out of this Q&A thing. Okay. And show a case that'll highlight this. All the cases that I show will be found in the AO fracture manual that's recently been published. Now here, Chuck and faculty, is another volar malunion. But the question is, how do you judge the rotatory problem? We know that the volar malunion, the patient presents frequently with a lack of supination, a lack of rotation. And is it just the distal radial ulnar joint that's involved, or is there a rotational deformity of the radius as well? Dr. Hoyne, do you have a way of judging that preoperatively as well as intraoperatively?
So yeah, that's a good point. I think this is what Chuck was alluding to as is the distal pronation deformity. And I personally, I think it's hard to see on radiographs. The tangential view helps because typically, I think, Jesse, what happens is that the dorsal part of the distal radius is in contact with the ulnar head or the seat, and that the volar part is angulated and rotated away. And you can see a little bit on that left-hand view. It's in contact as well as in the lateral, but then it rotates away. And I actually think that a CT scan on this is probably helpful. And you can go through each one of the cuts actually on the coronal view, because you'll see it maybe dorsally sitting close to the DREJ. And then as you move volar, it's going to probably rotate away as well as translate away. And I don't really get, I got a comparison X-ray to the other side, but not a comparison CT. So I think
Peter,
that
Peter
the CT is
Stern,
helpful.
with these, it certainly starts out with a length discrepancy between the radius and ulna. And these patients often lack forearm rotation, as mentioned. Do you ever think that there's a need to address the distal radial ulnar joint besides doing the osteotomy? Peter?
Yeah, for sure, Jesse. I think that first of all, if you do an osteotomy to restore just length, I find that in my hands, I can't lengthen a radius at one time more than about 7 or 8 millimeters. So you may be in a situation where you correct the lateral plane deformity, you still have ulnar positive and incongruency of the distal radial ulnar joint. So your choices at that point are for me, are either to do an ulnar shortening osteotomy or to do a DARA procedure, depending on age of the patient, presence or absence of DRUJ arthritis.
Okay, and Chuck, Cassidy, or Harry, you have a hand up?
Yeah, what made me think of something too is that, and Peter alluded to this, is if you can get it pretty close, maybe ask the group too, is a capsulectomy of the DREJ, especially the volar side, is that helpful maybe in obtaining some supination, and how do you judge that? And Peter, I think I'm along your lines. If I can get it pretty close in the rotation and length, and it's still a little tight, beginning proximal and then obviously preceding up to the volar limbus is maybe a release of the volar capsule of the DREJ. I don't know how many other people have done it. It's not all the time. I think it's only about a third of the time.
Thanks.
But
Joe.
yeah.
Okay, Chuck, Cassidy, Joe asks that he would love to hear some personal algorithms for early fixation of these. That is to say, what you quoted as so-called nascent.
Okay, yeah, so I just wanted to respond to that or add to it, and Hill just chimed in. So one of the advantages of a volar approach to treating these kinds of malunions is that the volar surface is flat, and if you use a pre-contoured plate, it will reduce the malrotation. Whereas if you're at a dorsal approach, especially if there's comminution, it's hard. There's not really a reference for rotation. So the Palmer approach or volar approach is, I think, a little better to identify the rotation. And through that incision, you could do the silhouette procedure, that Kleiman procedure, the capsulectomy. But you would want to correct the bone first and then see if there's still some residual loss of rotation, and then maybe address that. Okay. So there are some fractures, like I have one a really complex fracture, which was relatively well aligned, except one component of it that was not. And it would have been a very difficult thing to fix. Just let everything heal, and then you simplify it and just do an osteotomy of that one. The second is if the fracture is very, very distal, it may be difficult to get fixation within the radius alone, and it may be better to let it heal and then osteotomize it at an away point where you have more bone distally to work with. Alternatively, you could use a bridge plate.
Okay, well, let me show you some nice examples of correction here. A case of Dr. Diego Fernandez from Bern, Switzerland. But by tracing normal against the abnormal, one can get a sense of the preoperative deformity. And using through a volar approach, and then using K-wires as guides. And if you put the K-wires in with a drill first, not directing the K-wires straight into the bone, it will allow you to put the K-wires in and out and avoid it bending when you're maneuvering around the reduction. And so you can control not only the angular deformity, but the rotation deformity by the most proximal K-wire being perpendicular to the radius diaphysis, and the more distal K-wire being perpendicular to the metaphyseal deformity, that is the rotation and the angulation. And here you see it in the fluoro. Ideally, osteotomy we would like to do at the site of deformity, and it's being created here. And then by lining up the K-wires, in essence, you are correcting the deformity both in the frontal and the sagittal plane. And here he's used a lamina spreader to help gain some length and a correction. And as you pointed out, the flat plate on the flat surface helps to confirm the rotational correction. And here's the follow-up example. And so with these, we'll look at a little bit more distal and more complex deformity in this patient. She's 42 years old, and now she's 18 months with the deformity and having a good deal of pain and functional limitation. Peter, you want to describe what we're seeing?
I think, well, as you said, we're seeing a mature malunion of the distal radius, looking at the conventional parameters, probably between 30 and 45 degrees of dorsal tilt of the distal radius. Very, very important translation of the carpus without a DC deformity dorsally, such that the proximal carpal row is articulating with the dorsal lip of the distal radius. And if that's not corrected, there'll be radiocarpal arthritis, as well as shortening of say 5-6 millimeters and complete loss of, or near complete loss of radial inclination. I don't see any carpal pathology, and some apparent bowing, perhaps, of the ulna.
Do you think, Chuck Cassidy, that you can get the length with the radius osteotomy, or might you anticipate the possibility of an ulnar shortening along with it?
Yeah, I think in this instance, you can get the length. The ulna head is a little bit unusual. That cylinder, it would be helpful to have comparison radiographs. It's a funny looking distal ulna. The other thing, you asked me about 3D, and I use tracing paper. I think it's very helpful in terms of deciding whether to do a volar or dorsal approach, because you can cause, for example, if you did a volar osteotomy, volar approach, you can cause a big bump to develop on the dorsal side, depending on where you're making that osteotomy. There's lots of radial height and inclination, so it's going to be hinging on one point. So I do like to try to have some contact at some part of the radius between the proximal and distal segments, but it's going to pivot around the ulnar side to restore the radial height as well as the length. But I think you're not going to need to shorten the ulna.
Okay, Harry, would you approach this volar or dorsal?
I don't. Well, I'll give a simple, and that's my next talk. I don't think it makes too much difference. This is right at the borderline of angulation for volar for me. I think the volar we're very little more approach to is, and I also look at the amount of dorsal periosteum healing. If there's a lot of dorsal periosteum healing, and I have to release that significantly, then it's a dorsal approach. But I would probably say volar. I want to make one comment, Jesse. The large ulnar styloid fracture fragment and the convergence between the radius and the ulna, this radial shift. And I think that's a little bit easier to control from the volar side than the dorsal side, because when you in a dorsal osteotomy, you're often more pronated when you fix it or stabilize it. So as you can see how close the radius and the ulna are, and how the base styloid fracture is shifted radially. And that's a little bit, I think I can open up that distal interosseous membrane from the volar approach better.
Okay, so do you think there's a rotational deformity here, Peter Stern?
I honestly, Jesse, can't tell. I definitely agree with Harry that there is shift of the radially of the distal radius articular surface.
Because as Chuck pointed out, seeing this very wide metaphyseal distal fragment compared to the area of the fracture often would suggest a rotational mal.
Well,
Okay,
you could argue, Jesse, that that's settling of the fracture, and
Right.
so there's been invagination of the proximal radius into the metaphyseal portion. But at any rate,
So this was approached, and it was very difficult to get length. So the correction was done, both rotation and extension. But just as you see from this fluoro with the lines, there's quite a bit of length discrepancy. Chuck, how would you do an ulnar shortening here?
That is surprising, but yeah, I think I would do a conventional ulnar shortening in the diaphysis.
Okay. Do you think that there's any problem predictably when you've had a malunion of the radius and the sigmoid notch maybe not being in the normal position, I use that quote, of doing a shortening of the ulna, that the ulna head might not sit correctly? Harry, any thoughts on that?
Yeah, it's interesting you mentioned that. I just had a recent patient that I performed an ulnar shortening of a minimally displaced, slightly shortened distal radius, and the ulna did not seat completely into the correct spot of the DREJ, and there was a clunk with rotation.
Okay.
And it's there could be in slightly two different planes, and as you drop it down, let's say proximal, it may need some angulation at the same time. It becomes very difficult. The good news is in this case is that the lunate is completely covered by the radius now, so the impaction goes way down. It's when the lunate is in a normal situation. Some people have a certain covering of the lunate in relation to the ulnar or lunate facet, and this one has almost 80-90% covering, so the impaction goes down. It's when that lunate is translated over.
So
50%.
this had some bone substitute and an ulnar shortening done through the neck of the ulna and a little fixation plate applied, and her function was quite good.
Jesse, how do you judge the seating of that ulnar head in the sigmoid notch if it needs a little bit of angulation in the volar dorsal plane during the procedure? Because you really don't see it. It's hard to visualize it.
You addressed that point very well, that the advantage of going on the volar side in this case was your much better chance of correcting the rotation of the radius, therefore the sigmoid notch. And so as a result, it should, by dropping the ulna proximally, sit well, unless there's some injury into the sigmoid notch. But it's not entirely predictable, as you point out. So
Jesse, can you go back for 1 second?
Yes.
There's an important point. We're talking about, and one more slide back. We're talking about, if you go back one more, bone, but this is a soft tissue element, and here you actually put the styloid back where it belongs. And so when it's chronic and the styloid is off, it can get spot welded in a place where there's a cam effect, essentially. So your TFC is not in the right place, the rotation's not in the right spot. And that, I think, is part of the solution there, where you got that back where it belongs.
Okay, thank you.
Jesse and panel, do you have time for a question or should we wait?
Yes,
or
we
shall
got
Yeah,
time.
go ahead.
A
Go ahead.
couple questions from attendees. The first is a question that I've seen before, that after correcting the radius osteotomy and realigning the DRUJ, for some chronic malunions, the DRUJ instability persists. And if so, do you intervene at that time or do you stage it? And is it something that you commonly see?
Peter Stern?
Yeah, for me, being a little simplistic, just doing the osteotomy will be a full 2 to 2.5 hour tourniquet time for me. Then to do an ulnar shortening osteotomy or whatever takes more time. So I may very well stage it. I honestly believe that testing DRUJ stability intraoperatively is incredibly subjective, even if you compare it to the other side. I mean, there sometimes is gross instability, but I think it's very, very difficult to test. So I probably would stage it.
Thank you. Have one quick case here. Harry, 6 weeks post-injury. It's got a major deformity and carpal malalignment. Would you hesitate, all things being fine, the soft tissue being fine, would you wait or would you do an osteotomy now?
Well, the traditional method was sort of wait, and I have to give you credit on this, as over the years you've convinced me that this nascent pending malunion is best addressed now, barring any major issues. And I've done because of referral pattern now, this is almost a 1 in 4 case that I see. Every 4 or 5 cases I see one of these. So my vote is barring any other major issues, proceed with correction now.
Okay. Chuck, any thoughts?
I agree, but I would make the point, if you look in the lateral, the shaft of the radius is sitting almost at the articular surface, right? So it's excavated. There's not much distal bone. So I think you have to keep that in mind when you're deciding which approach, dorsal or volar, and how you're going to fix it, because you're going to have a small distal segment to work with. On the radial side area, your styloid area, you have pretty good bone, but around the lunate facet area, you don't. Whereas if you waited, you could just cut right through that and you could have a bigger segment of bone. So if you're scared to do it, you can wait. I would take it apart myself, but there's no problem, I don't think, with waiting. And if you don't feel comfortable doing it right now, unless of course there's carpal tunnel.
We have 2 questions really about gaining length, and one being involving the interosseous membrane and the other being release of the brachioradialis. Peter Stern, you had sort of alluded to soft tissues as well. Would you generally release the brachioradialis?
Sure. I don't think there's anything to be lost by releasing the brachioradialis. Interosseous membrane, in my experience, not so much.
Okay, thank you. So in one final point is, as you brought up, Chuck, that this may be a pretty small distal fragment. And going through a volar approach, sometimes we tend to use that to lever back the fragment into place. But at 6 weeks, the bone might be somewhat osteopenic. And one has to be a little careful, even with lock screws, of doing that maneuver. So in this case, maybe a dorsal approach might be just as effective as illustrated here, because we're not having to lever the fragment down. So now, Dr. Coyne, let's hear about some techniques and bone graft, et cetera, options.
Great. Okay. Can you guys see the screen?
We see you.
Okay, let me go back to Zoom here and share screen. Give me one second.
Here we go.
Okay, so my charge is technique. I'm gonna start my timer so I don't go over on my phone here. Approach volar and dorsal, which we talked a little bit about, but plate technique, the nuances of volar, dorsal, and let's say fragment specific, graft choice, autograft, allograft, synthetic, and some intraoperative details. And let's establish the baseline. The baseline, and I guess I'm the youngest, or Chuck and I are about the same age, is the traditional approach is dorsal approach because we didn't have angular stable fixation, a single plate, and autograft because the standard dorsally and radially displaced fracture needed correction, and a direct approach with a single plate was sort of the technique, and then autograft was considered the gold standard. And we have now is what adjustments can we use to this traditional approach. So I'm going to show an example of an individual here as a malunion example, which is a mature malunion. I like that term that Dr. Stern has used, history of rheumatoid and lupus. And I don't have the CT scan in this, but I chose a dorsal exposure. And the reason I have sort of this stepwise progression is that I think the steps are important. They're important to write down. They're important to think about. And it's a wide dorsal exposure, whether it's going to be fragment specific or a single plate. I felt that this was a best addressed from direct buttress, especially given her comorbidities. And incising the retinaculum, releasing the brachioradialis, and then proceeding with your planning intraoperatively. And this is what I'd like to get to align the K-wires along the joint surface and as close to the old fracture as possible. I think Dr. Jupiter alluded to that, as the best location is often at the fracture while being just proximal to the PRUJ. And I thought this was an excellent example because of where the K-wires were placed. And also, as you can see in the center area there, some of the issues of the DRUJ, which we'll get to in a little bit, and then opening the wedge on the dorsal side and temporary K-wire fixation. This is a different patient, but this is sort of the exposure from the dorsal side, and this is elevation of all of from the fourth compartment all the way over to the first compartment. In this particular instance, we chose then fragments fixation to maintain the congruity of the second compartment and the ECRL and ECRB tendons. And I find that during the correction here is that by maintaining some of that tension of the second compartment, it allows you to hinge a little better. And this is prior to the bone graft application. And what I wanted to highlight here is that on all of these dorsal fixation cases, especially on the dorsal ulnar corner, the plates need to be bent up and around to provide that appropriate buttress of the dorsal cortex as it comes up and contacts the edge of the lunate facet. I think Dr. Jupiter had that on one of his slides, and you can see here by also then translating that distal segment, the DREJ is well aligned. And then it's proceeded then with bone graft, and here's her final follow-up. Reasonable height, maybe a touch ulnar negative, but certainly very little DREJ pain and good incorporation. And this brings us to this topic, and I leave this as a teaser slide. This is one of my cases here, and the cancellus or cortical cancellus from the iliac crest had been the gold standard, but as you could see in all the other case examples, there are certainly many different other choices in cancellus, allograft, purely cancellus autograft. There's BMP putty in the middle, and this is one of the things which I really like is a bone marrow aspirate. And in instances where I'm going to use a cancellus allograft or something else, bone marrow aspiration at the beginning of the case, and either then with the centrifuge or something else, providing the appropriate autogenous bone factors I think are very important, and I think that'll be a great topic for discussion as we get going. And this is sort of the squirrel finding that bone graft. This is right outside our kitchen. And part of the type of bone graft is also paying attention to the gap. If one of the cortices is still maintained and not gapped or hinged, further hinged, as you can see here on this computer program, the plate is a little bit off of the distal segment and there's a big gap, that's going to require structural support. In my mind, and then that will bring us back to sort of the cortical cancellus versus some of the other situations where one of the sides, either the volar or the dorsal side, is maintained in contact. The plate has angular stability, and we're using the biology of the graft or as a void or a scaffold, and that then can be cancellus with or without autogenous or synthetic factors. But a lot more popular now, and I put a plug out to Kevin. Kevin was one of junior partners now and one of our senior colleagues and member of the education team, and he had a nice little early series of dorsally angulated fractures from the volar plate, and we talked about this and how do we do this. So I chose a case here to demonstrate, and as you can see on a lot of these, I am a big proponent of K-wire fixation intraoperatively in the line of the deformity parallel to the distal radius. As you can see in this case, there's also a K-wire placed from radial to ulnar. It really helps you understand whether you have a CT scan or not, or whether we've done computer guidance or not, the personality of the fracture intraoperatively. As you can see here on this slide, is I've placed it directly as I thought into the deformity, and I actually will take some little drill holes, as you can see on the left, or a tiny little saw, and begin to open up the old fracture. And the earlier, the better in these situations. And as you can see on the right, we're beginning to open up that fracture. This person also had a ulnar head type fracture, so we chose to use some osteoclasis there as well. And this, I think, is the key, and this is the technique pearl of the volar side. This is the same patient, is that you take a page from George Orbay and pronate that shaft out of the way, and then open up the dorsal cortex, release that dorsal periosteum, especially, I'll say it again, on the dorsal ulnar corner. If you want to establish that height on the ulnar side, the dorsal periosteum has to be released from the volar side. It sounds a little bit counterintuitive because we want to keep some of that biology, but you can't get that length without releasing that dorsal periosteum. And as Jesse alluded to, is it placing the plate then on the distal segment. Here I have some temporary K-wires, back the K-wires out, proceed with then application of the plate to the proximal segment. And in this instance, I felt I needed some further radial support. So there's other support along the radial column. And because it's angular stable fixation, this was cancellus bone graft as that void in this instance. So each one of these cases, as we go through, our faculty can maybe mention what type of bone graft they use. Just a brief thing on the computer assisted. I'll show a case, and this is 2003 from our Canadian colleagues demonstrating. This is from the dorsal approach with their own computer program. This is now evolved into some more sophisticated techniques. This is a case courtesy of Peter Evans. And I don't think there's anything special about the radiographs other than the dorsally displaced, very mature distal radius. To do this, though, you need CT scans of both extremities. They superimpose them for correction. You plan the correction. Here's the correction plan. In this particular instance, is a dorsal displaced fracture, volar planned correction. There are two guides, one for the placement of the plate, the other for the saw. Here you can see that these are placed initially for the for the final and original screws. And I think this is a little bit of the difficulty. And sometimes you lose the personality of the fracture just with the computer. You really can't see anything anymore here, Jesse, can you? This is gone, the visualization. So you sort of have to trust yourself. And here's making the saw cut. Again, this is really trusting the, let's say the computer itself. Very similar situation, application of the plate back to the bone. And then sort of the final correction. In this instance, as you can see here, this is cancellus bone graft. So I'm gonna finish up because I wanted to try to stay a little bit on time. And this is a bit of a teaser for us and maybe food for thought for some of the case discussions. Thank you.
Thank you, Harry. If you get out of your screen now.
Yep. Let me stop sharing. Hold on. where is this here? I lost the,
Up on top.
yeah, it went show
We
grid.
did have one
Yep.
question
Yep.
about the use of external fixator as a distraction device intraoperatively. Have you had experience with that?
Only occasionally, not so much in the distal radius. I haven't needed it, but it certainly is something that that we can use if necessary.
Mhm.
I lost my, oh, here, stop share. Okay, there you go.
Okay.
This is if I guess it's if it's a large defect and you want to hold it to a certain extent, maybe an extra across the joint,
Okay.
but not very often.
Okay. How about this case, Dr. Cassidy? A very complex fracture with, as you see, it's really an extra-articular distal radius problem, but a very substantial length issue.
Yeah.
Would you potentially consider doing a combined radius and ulna here?
So this is interesting. So it looks like it probably was an open fracture. It's surprising that it would shorten by that much. So I would worry about an interosseous ligament injury. Is there a radial head fracture? It's hard to get 10 millimeters of shortening. But that having been said, so I'd like to know what the distal radial joint looks like. The radius needs to be corrected. So, that I think that one to me is more straightforward than what to do with the distal radial ulnar joint. And as I mentioned earlier, and I think Harry, you kind of pointed out, you like to leave a little bit of contact between the proximal and distal segments in the radius. I don't like to jack the thing open so that there's no contact whatsoever. If I can help it, I'd rather shorten the ulna. But I'd make the radius anatomic, not expecting that I'm going to regain all the length, and then probably shorten the ulna.
Okay. Yeah, there was a paper years ago that looked at malunion of the radius with the orientation of the sigmoid notch. And so correcting the deformity is very important to realign the sigmoid notch when you have to do an ulnar shortening as well. Peter, you think that you could do this just with a radius?
Not a chance in the world. I'm sure you're going to have done it though, Jesse, using a distractor. Every time I use a distractor, the pins break the bone that I'm, cranking on, but I'm going to see it.
No, no, that's a very difficult case. I think it requires both. Harry, you have anything to add?
No, I'm concerned this is going to be a non-union problem because of the sclerosis of that radius. It looks like ivory bone there, doesn't it, Jesse?
We had one question, Harry, when you did your volar osteotomy about
Yep.
putting in the bone graft. Is it difficult to put in the bone graft through once the plate is on in place?
Yeah, absolutely, because you can't see that dorsal ulnar corner anymore, can you? If it's not a gap on the volar and the dorsal side, it's not a structural graft, then I use the radial window after releasing the brachioradialis. I put the graft into there. If I think it's going to be this structural graft where I've been heroic and done iliac crust, then I place it first, K-wire, and then the plate.
Chuck, one thing we didn't really address so much is when you're doing this through the volar approach, do you have to release the periosteum on the dorsal side if you want to gain a realignment and length, or can you just stay all on the volar side?
Well, Harry showed a way of rotating the bone out and incising it. You can use a laminar spreader like you had shown before and gradually stretch it out, or even through, if you gap it, and you could wedge an osteotome in perpendicular to the shaft, or and then keep it open, and then just cut the periosteum through the volar incision
Right.
carefully. Yeah.
Okay. So let's see here. And this was done with a dorsal approach, and did have an ulnar shortening osteotomy, and a functional follow-up picture you see here. Now here's another case of a 35-year-old fell from a bicycle, and he has primarily an extra-articular deformity. He has a little bit of fragmentation of the very thin dorsal cortex, but really look at this as an extra-articular deformity. And this is 3 months after an unsuccessful cast treatment. Peter, your thoughts?
Yeah, do we have plain radiographs at 3 months, Jesse, or did I miss
Not
them?
at 3 months, just a
Well,
CT.
You know, that's a very thin sliver of bone, which is the distal radius segment. I think it would need to be, this would be one, as Chuck mentioned, that you might want to have consolidation rather than doing a nascent osteotomy. You may have a lot of grief if you did that. I would, if I'm looking at things correctly, I would probably approach this dorsally with a plate or some fragment-specific plates or wire forms, I think, with bone graft.
So you highlight several things that we addressed a little bit. As Chuck Cassidy pointed out, you'd like to get the soft tissues compliant. There's nothing to be gained by operating on a stiff fingers, and especially if there's any neurologic issues. And secondly, the fragmentation or lack of use of the distal radius may have disuse osteoporosis, and that may be a little bit more difficult for fixation. So the idea of staging this, not necessarily on the basis of the x-ray, but the time is also very important. And so let's see what was done. This was a dorsal approach. And once again, as Harry pointed out, the use of these inter-operative wires to give you guidance as to the realignment, the osteotomy done at the site of the deformity, and the correction per se. One of the problems with these osteotomies is translation of the radial segment. Chuck, any thoughts about that? Once you've corrected it, you can see that this radius seems to be somewhat translated.
Yeah, there are a couple of approaches. Well, I like what you're doing there. You could put a fixator on the side. You have a fixator dorsally provisionally. You can put a plate along the radial column, and that will push it over. Or you can put a laminar spreader in the interosseous membrane between the shaft of the radius and the ulna, and that will drive it over as well.
Right. So I fortunately got this case in to answer the question of one of the participants about the use of a fixator. And so sometimes it's judicious in its use to gain your length. And here's your defect in the intraoperative fluoro. And the two-plate technique, as Harry showed, is in use here. Years ago, when we started having the angular stable fixation, and we all were using corticocancellous bone graft, I always found it difficult because it's a three-dimensional deformity and defect. It's very hard to fit in the corticocancellous piece that it fits just right. And I just started using pure cancellous bone. And as long as you have stable fixation, it heals very well, but it also fills the depth of the defect very effectively. So here we've gotten length and filled it with the pure cancellous bone and post-op x-rays and overall function.
Just
I-
a
I-
comment.
Yeah,
It's very important to have volar cortical contact with that to avoid it tipping over in the other direction. It can the plates that are at right angles or 60 degrees. I think that helps a lot, but still it could tip if it's jacked open and there's no contact in the front. It could tip over the other way.
Yeah.
And one other point is there was a paper which I'm still astounded with dorsal opening wedge osteotomy without bone graft that showed good results, just leaving that gap and let it fill in, which I have not done myself.
and one last use of a fixator. What do you think about this, Peter?
Bad.
Bad.
Yeah.
It's
Yeah, I probably would like to see some more imaging. This is severely, there's probably a sagittal and coronal plane deformities here. I would very much like to see a CT scan. That's clearly unacceptable currently, but I don't have enough information to speak
I just
intelligently.
wanted, because we had questions about the use of fixator. If you look at this very small distractor, look at the blue arrow. And so when it's put on, this is put on somewhat in the angle of deformity, and this is perpendicular to the radius. And now look at the blue arrow here. You can see how much distraction one can get. The downside of this is if this bone is osteopenic,
See you
this
later.
is going to loosen. So you have to do this very slowly. But to get a big length, sometimes, as was the question was asked, a distractor is very helpful. And so you see, this is all cancellous bone that's filled the defect. And this patient had a good functional result. So
Jesse,
one question is, how do you choose your site for osteotomy? I think that ideally it's at the site of the original fracture.
Yes,
And
agreed.
then, Chuck, is there any means or tips to correct carpal subluxation, which is challenging in neglected cases?
Well, so there's the mid-carpal instability, which is an adaptive instability pattern that should correct as you correct the radius when you get the volar tilt back. If it's really a radiocarpal instability pattern, that's not necessarily going to be corrected by an osteotomy. And that's where limited fusion is the
Yeah,
only
there are
fusion,
really
limited fusion.
two kinds. One is as a result of the malunion that you'll correct that with the deformity correction. The others may be as a result of intercarpal ligament injury that remains as a fixed carpal malalignment. Yeah.
Yeah.
Okay.
So, Hill has a couple of comments. He's quiet tonight, but he pointed out that Tom Fisher, one of our colleagues and faculty members, did a study that compared volar or dorsal plating versus 90-90 or 60-degree plating, and the dual plating was much stronger, or it was significantly stronger. The second is and Jesse taught me this, if you have significant deformity, it's usually forearm, but with a lot of deformity and shortening, that an Elizaroff and gradual correction may be an option.
One of the final things about and it came up as interosseous membrane, is that when we're trying to translate the shaft radial, okay, is that releasing the periosteum and the distal band of the IOM off of the radius, and that can be contracted and tight, and you'll form some new fibers there. But I don't hesitate to really try to open up that space, especially off the radius, when I'm having difficulty moving the radius from ulnar to radial. And that's,
Great.
I think, Chuck, you pointed that out, the soft tissue problems are just as important.
Okay, thank you. So we're going to go on to intra-articular malunions, and really I've got to figure out what are the indications, because there are selected indications for this. What are some of the surgical considerations and outcomes? A couple of references written about this problem in the JBJS article 2005 gave our early experience with this, and textbooks that you'll find this in as well. As we heard from the initial presentation of Dr. Cassidy, is the outcome always predictable? We've all seen these patients that show up with deformity, awful looking x-rays, and are virtually asymptomatic. And we've had studies, this one from St. Louis, finding that even following identifiable radiocarpal arthrosis, patients can be functioning very well. At the same token, if it's not well reduced and associated with carpal problems, as we found in this study, that a certain group of these patients will not do well. And therefore, it became interesting to find out if there is a role for correcting the intra-articular deformity. And what we found from this initial study is if you have a major step off, but importantly have carpal malalignment, there's arthritis, and some of those patients will not function very well. But if you can restore that, even in the face of deformity that it existed, patients might fare much better. And so a patient like this is something we'd like to avoid because they've got not only intra-articular deformity, but a malaligned carpus. And when we have the intra-articular distal radius malunion, not only might we find carpal malalignment, but it might be fixed and might not be correctable and might require, as we'll hear, certain salvage procedures. Then the second question, we didn't have much concern with the extra-articular malunion osteotomies of healing, but will these heal? Is it technically feasible? And if you're lifting up small articular pieces, is avascular necrosis a problem? Ideally, as was pointed out, good imaging is very important to understand the nature of this. And in this case, virtual planning, as you saw, might be helpful because these deformities are often three-dimensionally, and we're usually looking either from the top or the bottom surgically, and we may not appreciate the entire extent of the deformity. We also would like to have at least a feeling that the cartilage is still present, but as it turns out, timing may not be as critical as one might think. But certainly there are contraindications, and all of these, as listed here, I think are self-explanatory per se. So our first series looked at 26 patients in 3 centers, and we had mostly a younger age population. But as it turned out, all the osteotomies healed. Some patients required implant removal, as the implant fixation is often very distal and can be prominent. But radiographically and clinically, the patients fared, at least for a relatively short time, pretty well. And we haven't seen late deterioration. And as is expected from complex surgery, there were some complications. Now, what happens if you have combined intra and extra-articular osteotomies, like in this patient here? This is a man I saw many years ago who was a general surgeon with such a deformity. And at that time, we were able to make virtual three-dimensional models of the entire deformity and the normal side, and could actually plan your osteotomy, not just virtually, but really with the models. You can see the rotational deformity looking end on compared to the normal side. And it turned out that by elevating up that lunate facet and then doing an extra-articular correction and it took off the head of the ulna, he had a very reasonable functional outcome. Here's another patient with a very complex fracture that healed with a major deformity. And what you're looking at is some granulation tissue on the proximal carpal row, and the dorsal part of the articular surface is impacted, and there's an extra-articular malunion. And she had a nice correction, and this is a 3-year follow-up, and to my knowledge, there's no further problems. And finally, we looked at a series of these and looked at 20 consecutive patients, and 17 were evaluated at 4 years. And this is a good example, because if you can define the fragments, then the surgery is actually less technical than doing a fracture. And so the fracture fragments here are outlined as such. And by first correcting the lunate articular deformity and then the extra-articular deformity, actually it's a controlled procedure. And here we have the schematic and then the extra-articular malunion correction. And once again, with these dual plates per se. Plates were removed. This is a case of Juan Del Pino in Madrid. And looking at this series, patients generally healed. And the important thing is that we didn't see late osteonecrosis or late arthrosis, and their overall function improved substantially. So in conclusion, these can be challenging, but the queries that we had, that is, could these heal, turned out to be not so much of a worry. And we did not see AVN, and at least in the relative short term, the results are fine. Complications with these are probably due to poor planning, generative changes, or fixed malalignment of the carpus per se. And so our experience has shown with careful patient selection, refinements of the technique, lower profile implants, even the use of intraoperative arthroscopy might be very helpful. So with that, I'm going to move to Peter Stern because we can't always do these things, and we sometimes have to salvage.
Jesse,
Peter?
can I ask you one quick question?
Yeah.
Paco del Pinel from Spain has written about doing arthroscopic intra-articular osteotomies,
Yes.
something I've had no experience with,
Yes.
but do you see a future in that, or is that for?
Well, you have to be very facile with arthroscopy and need very special instruments. He took some very small osteotomes, bent them, and created a better controlled situation. I think as arthroscopy has become more applicable, it certainly might be a way, especially in controlling a deformity. However, remember that with arthroscopy of the wrist, you have a parabolic distortion. So sometimes things look bigger or worse than they might be. And that's why combine that with good preoperative imaging may define the problem a little more clearly. I don't think it's your first time of an osteotomy to do this, but the selective cases, the best ones are the Barton's fractures, that the single 1 or 2 volar shearing pieces that can be brought back more clearly. And then you can look at it arthroscopically to make sure you've realigned the situation.
I've
Okay,
used it
Peter.
for radial styloid, but I would tell you it's a test of friendship with your nursing staff to ask for the scope in addition to the CR and the fracture stuff.
Okay, Peter.
Okay, can you see that?
Yes.
So this is going to be a very short presentation followed by a case. I'm basically going to talk about salvage of distal radius malunions.
Hit your screen with your cursor. Hit your screen.
Okay.
That's it.
Yeah, thanks. So first, I'll start off with an inflammatory statement. Is wrist motion worth saving? My response is probably. However, I believe wrist range of motion is overrated, and I think the two most important motions in the upper extremity are forearm range of motion, pronation and supination, and finger range of motion. As Jesse has pointed out, if you were to do something such as fuse a wrist, patients really don't like that. But I would again say that my single greatest goal in a acute distal radius fracture is preservation of digital motion and trying to maintain as much forearm range of motion as possible. I find that most patients are fairly happy with a fused wrist. They get used to it. So what are the considerations in terms of arthrodesis versus reconstruction? Well, most of these have been alluded to already. So age and overall health status. Doing a distal radius osteotomy is a pretty big deal. A wrist fusion is very easy to do. So perhaps in the senior population or someone who is not particularly healthy, arthrodesis may be your choice. I already mentioned the importance of range of motion of forearm and fingers. You want to get the soft tissues as soft and pliable as possible before you embark on a reconstructive procedure. I think that if there's significant arthritis in either the radiocarpal joint or distal radial joint, osteotomy may not be your first choice. Bone quality is critical. I'm having a case right now of a lady who's smoking. I've just destroyed everything because I can't get the osteotomy to heal. As in another article from the West Coast, it was pointed out, not all osteotomies go as smoothly as they do in Dr. Jupiter's hands. There's a 51% complication rate. And finally, if a patient is free of pain and they're fairly low demand, I might not do an osteotomy. I don't believe in operating on x-rays. We operate on patients who have problems. This is a study that was already alluded to, Lou Catalano's study. It's a classic that was published in JBJS. A series of young patients that had operations for distal radius fracture. At 7 years follow-up, 3/4 of them had radiographic osteoarthritis, but they were all functioning well. Bottom line being that salvage procedures should be based on function rather than x-rays. There was a subsequent study that Chuck Goldfarb published, 15-year follow-up, similar results. Here's a patient of mine, not as bad as the one that Jesse showed, but this was a lady who had a distal radius fracture. X-rays look pretty bad with markedly positive ulnar variance, a distorted articular surface of the distal radius. In follow-up, 4 years later, she has full forearm rotation, no pain, no complaints, relatively limited wrist flexion and extension, but a happy camper in a senior patient. So areas that you assess with a distal radius malunion, and we've talked a lot about this, are both the radius articular surface. If it's dusted, you're going to need to do probably a wrist arthrodesis, either complete or partial radioscapholunate type fusion. You're going to look at dorsal translation and midcarpal instability, as we've gone over several times before. And terribly important is the integrity of the soft tissues. I would caution anyone to do an osteotomy of the distal radius in the presence of significant edema or digital stiffness. You're going to be a loser. So in terms of treating symptomatic radiocarpal arthrosis, there are two choices. One is an arthrodesis, the gold standard. The other choice, if the mid-carpal joint is well preserved, is to do a partial wrist fusion. Usually I do a radioscapholunate arthrodesis, occasionally just one of the two bones. Arthroplasty has been written about from the Philadelphia group. Many of the arthroplasties here were not for malunions, but for radiocarpal arthritis. I would just say that wrist arthrodesis in the arthroplasty in a post-traumatic setting is fraught with errors. And even in this very optimistic group from Philadelphia, 51% complication or revision rate. So my thoughts are that we're not ready to be doing arthroplasties, and I don't have time really to discuss the distal radial ulnar joint. Here's a case example. This is a patient of mine who presented 15 months after an untreated Colles fracture. You can see marked narrowing between the scaphoid facet to the distal radius and scaphoid, as well as dorsal carpal translation. A picture, a photograph taken at the time of surgery, complete eburnation of bone on the distal radius and scaphoid. And this was treated with an arthrodesis. Patient was very happy and went on about his way. In terms of radioscapholunate fusions, this is certainly another consideration. The fusion itself, in terms of fixation techniques, can be done with K-wires, staples, headless compression screws, as Mark Cohen has eloquently shown, as well as dorsal plates. The results in the literature of so-called Chamet or radioscapholunate fusions are pretty good. They're reasonable. Mark Garcia Elias has recommended, if you do this, that you excise the distal pole of the stake of the scaphoid because it facilitates the dart thrower motion. The one problem that I've seen with these is that if they're not done pretty well, non-unions, and the other problem being future mid-carpal joint arthritis. I'm going to present a case, if it's okay, Jesse.
Yes, yes.
Okay. Could you guys close your, I can't see my screen. Could you close your videos, if you don't mind, Chuck, Harry, and Jesse? Great. Jesse, you stay on. So this is a case I treated recently. It's a 54-year-old right-hand dominant female. I did not initially see her. She presented with right wrist. She had presented with right wrist pain. Her story was that she had bilateral distal radius fractures, treated operatively north of Cincinnati in April of last year. She presented to me about 2 months after one of her fixation, her right wrist. She was healthy and worked as a paralegal. This slide merely demonstrates that her sensation was intact. She had good range of motion of her finger, no evidence of a compression neuropathy of the median or ulnar nerves, and she had reduced range of motion of the wrist as well as forearm and markedly reduced grip strength. These are x-rays on the date of injury. They almost look like they're traction films. These were not taken by myself. Jesse, since I can see you there in Hawaii basking in the sun, what do you kind of see here? These are not my x-rays. There are no tricks here.
No, I see a fracture in the end of the radius.
Good.
Yeah.
Great.
I'm not sure about her carpal alignment either.
Okay.
But she has
Nothing. The carpus is okay.
No. Okay, I see a volar displacement as well.
Okay. What do you want to do?
CT scan.
Okay. No CT scan available. Scanner broken. Patient has no insurance.
Well, I think there's an intra-articular fracture on the volar side.
Okay.
I would fix that.
Okay. Patient came back to the treating surgeon 10 days later, Chuck, and these were the radiographs that were taken.
Well, that's unfortunate. There's volar escape, volar radiocarpal subluxation. The volar ulnar corner was not captured by the plate.
Okay, so Harry, the patient is now referred up to the Cleveland Clinic, the other end of Ohio.
Oh boy, yeah. These are ones that are difficult, but this is really going to be a functional problem at a later date. So
Okay.
attempt revision with added things. We can have a long discussion, but the carpus is really not articulating with the rest of the distal radius.
Yes, okay. So what do you think about this? This is what the treating surgeon did.
I think as long as the surgeon holds their hands on the patient for 6 weeks, it'll be all right.
Okay, so, well, in the casted version, there was no.
Looks okay. Yeah, right.
Hold the carpus up. So that's 10 days post-op. Patient comes back at day 25. And Jesse.
Right. Get a CT scan. And then,
Okay.
okay, wait a minute. So now it's gotta be repositioned, and it needs something to prevent the carpus from subluxing. So probably a dorsal bridge plate or external fixator, but you need a much better control of the volar ulnar fragment. But at 25 days is still an opportunity.
So this is what it looks like at 45 days. And I think this was when I saw the patient. So really as all of you have mentioned, the cat was out of the barn, and she still had palmar subluxation or almost dislocation of the carpus. I just have a couple CT cuts, but the distal radius articular surface was in very bad shape. And we went on to explore through a dorsal approach and ended up doing a Cham-A radioscapholunate fusion. She had 2 weeks, 4 weeks, pronation, supination. Here she is at 4 weeks post-op, much, much happier. She's got pretty good extension, probably 30, 40 degrees. She's got full pronation and supination and full range of motion of her fingers. So I was extremely happy with this outcome, and I've run out of time. I have another case, but it would take much too long, and we're approaching the end. I would like to hear from my dear friend, Dr. Jupiter, for closing comments.
Okay, thank you. Can you get out of your screen?
Yeah. I'm gone.
And Peter, any thoughts about doing that from a volar approach? That midcarpal realignment and fusion?
So I haven't had any experience. I'd be curious to know exactly where you're going with that.
No, because you had to take the plate out. You're on the volar side.
Sure. We actually took the plate out first. So I don't have any real thoughts on that. I've always done it through a dorsal approach, which is a flimsy response.
Okay. Well, let me go in the interest of time here to you remember this case? Okay. This is the index case.
Correct.
And this was the preoperative drawing. And it was chosen to do a volar approach. As was mentioned, release of the brachioradialis is really important. And I think if you want to get a better correction and facilitate the realignment of the distal fragment, we need to go dorsally and release the soft tissues. And the periosteum is very thickened because it had fractured, and release that. Something I learned the hard way is if the Lister's tubercle was not fractured and still intact, when you bring down that displaced distal fragment, you may make that Lister's tubercle very prominent. And we had a series of patients who ruptured their EPL by attrition over that Lister's tubercle. So it's worth nibbling that down as well. And a plate was used to realign the fragment, and both in the frontal and sagittal plane. So correcting the radial tilt, so to speak, and the angular deformity in the sagittal plane. And then what was mentioned is the use of a laminar spreader. And laminar spreader can be used to both help regain length and then sliding the plate distally, as well as Dr. Cassidy pointed out, putting it between the radius and the ulna to bring back the radial shaft and correct that tendency for the distal fragment where the plate is attached to radially translate. So as Peter pointed out, the soft tissues are very important here. And to get a better correction, you really have to concentrate on releasing these soft tissues. And here's the defect, and bone graft can be applied through that defect pretty successfully. And here's the follow-up as such. Well, it's 3:30 and well, 3:30 in Maui. It's 8:30 for you guys. And I want to thank everyone for signing in and participating, and thanking the faculty and thanking the AO support staff for allowing us to present this. One positive note is because of the interest and the experience with operative treatment of unstable distal radius fractures through a volar approach, we tend to see much less in the way of malunions than certainly I did when was starting out as well. There's a final question is, did the patient develop carpal tunnel syndrome? Not to my knowledge. So I think we hopefully have addressed our challenges. We've identified what deformity does to function. We've identified the approach in preoperative planning, the use of newer methods of imaging. We've looked at some of the techniques of correction from the volar side and the dorsal side, some approaches to correct rotation, looked at the role of the distal radial ulnar joint, and looked at intra-articular deformities, both salvageable and not salvageable. And with that, we'll turn it over to Dr. Cassidy and Rizzo because they have an important announcement.
Well, thanks. My most important announcement is to thank you, Jesse and Peter, our mentors for all of us, for the opportunity to present with you today. It's really been a privilege. Want to thank our faculty members, those of who behind the scenes have answered questions during the session. And I want to remind people that we have this ongoing series on Thursday evenings at 7 p.m. Eastern Time, except for the third Thursday of each month, where we're on hiatus for the Hand Society Fellow Debate for the next couple of months. So we're going through the second week, I believe, in April. Next week's session is on perilunate injuries, and Peter Ray is the moderator. Marco, do you have any comments?
Other than to say thank you, Jesse, Peter, Chuck, Harry, wonderful work. Thank you for the That's faculty for being here. One last question for Dr. Stern from Dr. Hastings. Patients with RSL fusion with distal scaphoid excision and trapezial excision, can they really lead to MC instability as recent lab studies suggest?
I feel I don't know the answer to that. One of the things that bothers me with taking out which Mark Garcia Elias has recommended is it improves mid-carpal range of motion. My hang-up is that if you try to take the distal pull of the scaphoid out and you've already fixed the proximal pull to the radius, it isn't as easy as you think. So I am kind of a chicken and don't ever take the distal pull out. It is a deep structure which is not as easily removed as you might think. Just do it.
This is what I love about the AO. This is just wonderful stuff to
We're just getting started. Yeah.
We're just,
what I do.
Yeah.
I'm in a minute. You guys have the stage.
For that thing, what I do is I make a small incision on the volar aspect of the wrist over the scaphoid tubercle. And through that, you can take out the distal pole of the scaphoid and put your screw right through there. So you have a straight shot at it. And if you take out the triquetrum, you've got another shot straight at the with another screw. So you have two screws, which are one going from the lunate, one going from the distal scaphoid, and that makes it very simple.
I love it. Thank you.
So it does take off the stress on the radiocarpal joint, but the question is, does it lead to mid-carpal problems later on?
I have followed 20 cases and I have not seen that, sir.
I haven't either.
Okay.
But it's in the literature recently.
Yeah.
Thank you.
Thank you again, everyone. What a wonderful session. And I look forward to next week and weeks to follow. Thanks again.